All right. Hello, everyone. I apologize for going live and then totally stopping, but hopefully, uh, we have a couple people join in. I am really excited to have this conversation today. I was sharing my excitement before we started recording just about the group that we have. And it just so happened that they already are connected in some ways. So just great collaborative representation already. So before we get into our panel questions, I want to give everyone a chance to just introduce themselves, tell you a little bit about who they are, what they do, and then we'll get into it. So I'm just gonna go based on who's on my screen. Tyler, you want to get us started? You didn't tell me that, Tyler. I would have never asked, but thank you for showing up. I appreciate you. All right, Nathan, you want to go next?
Yeah, I'm Nathan Riley. I'm a OBGYN. I do home birth, and I'm a father of two little girls.
Amazing. Thank you so much. Rose, how about you?
Hi, everyone. I'm Rose Fortin, and I'm a nurse, an OB nurse, even though now I'm functioning as the CEO and founder of a Not on My Watch Consulting Partners, where we support nurse leaders and we support organizations. My life's work is to mitigate maternal and infant morbidity and mortality.
Amazing. Thank you so much for being here, Rose. And last but not least, Tulsi.
Hi, I'm Tulsi. I'm a pelvic floor physical therapist. I am predominantly in New Jersey and I treat women in the comfort of their own homes. So, as a mom of two, I want to break the barriers that we have when it comes to um, preconception, fertility support, pregnancy, postpartum, and just our whole entire recovery.
Yeah, so crucial. Thank you so much, Tulsi. All right, so obviously the PRC is all about collaborative care and impact and making sure that the very fragmented system that we all currently live and work in, um, can slowly make cohesive transitions and defragment. So beyond collaborative care being a buzzword or something that, is trendy, how do you guys, and this is open to anyone, how do you guys see it in action, right? Like whether it's in your practice or your company or in your local area.
Well, I can get us started. As I think about the hospital setting, sometimes we do a really great job with collaborating, right? If the charge nurse in labor and delivery gets a call from a physician's office, hey, we have a patient coming in, she's at 25 weeks gestation, she's actively laboring, then we activate everything, right? So we notify triage, send the patient right back, we get a room ready for her, we notify NICU, and we do a really great job collaborating that way. I think a good definition of collaboration as it relates to healthcare is centering the needs and the voice of the patient. And I think that's the opportunity we have. In my first example, yeah, it works really well with something like that. But that overall collaboration of ensuring that we do what really centers the needs of the patient in the hospital setting, I don't think that we do that perfectly, and we have opportunities to do a better job at that. This is my thought.
Yeah, I would have to say I agree. You know, outside of the hospital system, which is predominantly where I work, I feel like we have to really include the patient, and that's kind of often forgotten about, right? Like it's not our goals as providers, it's the patient's goals, their role, like what is their needs and their wants. And I really feel like as a practitioner, we have to understand other practitioners like value and their philosophy and not go in with our own goals. And I think that is like such a big I think we all understand that, but I think we forget that sometimes. And like how can we make that come together? Like how can we be the voice of the patient when they're not necessarily there, but like, they might be telling me something, they might be telling the OB something, and like there's a lot of common themes that we may see, but what what are we trying to really solve? Is it like our agenda or theirs? And I think that has to really be understood. And like, I always say like we have many connections, but collaboration happens when like that team really comes together and like, you know, brings the patient into it.
Anyone else want to jump in?
Yeah, I would like to. Um, I always have this apprehension coming into, these types of panels because my perspective on the provision of healthcare services has changed so much despite all of the medicine or whatever that I've learned in my life, and how many times my wrist has been slapped for not coding in the right way and not documenting in the right way and not being productive enough despite 100-hour work weeks in residency, and then just losing my patience with a nurse and then having to be remediated, like all of that stuff where you have to be like this such a well-behaved little cog in the machine. And I'm hearing words like provider, which actually has one presumption. It means you can bill on behalf of medical insurance. I didn't go to school to become a provider, and none of my colleagues went to schools, to become a provider. And Tulsi didn't go to school to become a provider. She went to school because she really cared about people. So we have this sort of top-down engineered system that really makes it feel as much like a sort of composite of different parts that are not really granted the autonomy to just do what's right by people, because you have to fit into your job role. And so true collaboration really requires us to to unfortunately like really reconcile this reality that we're being employed to make money, to not take care of people. And that's a really, really sticky thing. If it was about taking care of people, then we would actually be very, very clear about how much time a person needs in the postpartum space. They don't need a 6-week visit where you look at their vulva and touch their breasts a little bit and then say, you can have sex now. They might need actually 40 more hours worth of time with the person that they have a trusted relationship with, or a combination between me, Rose, and Tulsi, and their midwife, and their doula. And then, I just got back from a 5-day men's retreat that I hosted. It was MDMA assisted. It was a whole bunch of very, very interesting things. And these are dads, new dads, soon to be dads. And like, they're not a part of the conversation. They desperately want to be a part of the conversation. From all backgrounds. This is not like a certain, facet of our society. So I don't want to get into a diatribe here because we have more questions. But, the reality is that when we start looking at this as a business entity, which it is, that's what it is. It's a business entity, the medical industrial complex. It makes it very, very hard to care for people when you have no real way of caring for a family within a system that's where collaboration actually is disincentivized. So what do we do going forward? I really don't know, but I think it's a good question. I think it's a really important. I think to start to answer it, we have to really look in the mirror and realize like what we've created here, how well it serves us as an industry.
Yeah, and Nathan, honestly, one of the biggest reasons why I, invited you onto this panel is because of that perspective, because I don't think collaborative care is probable, I won't say possible, probable in this within the system that currently exists today. And I think we have seen since like the COVID era more women and birthing families exiting that system in certain capacities, but the realistic, truth is that it's not going to be in a big enough way to actually change the system, right? There's not enough people standing up saying like this doesn't work for us anymore.
Right.
Which is unfortunate, and I'm grateful for people like you and most of the, and even Tyler for Tyler, I know you missed that, but for companies like Unravel Healthcare and Team Birth trying to do this cohesion within the system. But we talk about the frustrating limits that we have, and Rose and I have talked about this as well, all separately. So I think just recognizing that is a really important point, and I'm glad that you brought it up. And even personally, like I've had two births at home. I had one in a birth center. I had one in a hospital. All so different. And most people don't have that spectrum to kind of see all the different views. And I like to try to, I try to share that as much as possible, because so many people are like, no, I have to go see the OB. I have to go, deliver at this space because that's what my insurance covers and that's what my husband wants. And, I think a lot of, to your point with the partner conversation, it's this fear that partners have, that they just don't understand that there's other options, and that those other options are potentially even safer because you do have a connected team working with you in all the facets versus just a provider, to your point, that is able to code and bill and spend X amount of minutes with people. So like I said, super, super happy to have that conversation here, and kind of, collaboration in action, as I like to call it. Like, this is the point of the catalyst conversations. How do we begin to even move in that direction? Or how do we at least do our part to, impact even just a few moms or families that can be better? So Tyler, I want to just give you time to answer if you want to, because I know your internet was jumbled there, and then we'll move on. But
Yeah,
I
I
see,
fixed it.
okay,
Yeah, we should be good.
no problem.
Thank
Listen,
you.
I
No,
I get tech, but
yeah, I really appreciate that point, and I think it's incredibly challenging, because I mean, I'm a big believer in working within the system to make it better, because I think the reality is not everybody has the option to like leave the health system, and like go and select other things. I think, especially a lot of things that exist outside the health system, and I mean, please correct me if I'm wrong, but is self-pay and can be expensive. And I just think the reality is some people have to work within the system and try to make the system as good as it possibly can be, recognizing that it has flaws while also trying to create opportunities outside of the system. Um, and I mean, this is just kind of where we're at with Team Birth at the moment, is trying to spread and scale it so it's the standard of care for every patient that's giving birth. But also recognizing that there are a lot of really great options outside of the system that I think people should be able to have access to regardless of their ability to pay. So,
yeah, I know Nathan and Tulsi, you had your hands up, so if you want to continue on this, happy to hear either of you, and both of you. Go ahead, Tulsi, you can go.
Yeah, I was gonna say, like, I agree with Nathan. Like, I think there is such a breakdown in the system when you think of it as a business entity, which it is, right? Like, any provider is going to, or any business is going to, like, what am I doing? Where's my time? Where's my money, right? And it is all down to dollars and cents. But I also say, like, this is where our education, like, as providers or as caregivers or whatever space we're in, it goes that extra mile. Like, I'm always asking, not just my mom's or like not just my dad's, but like because I treat in the home, I get to be like, where's your support system? Like, where, like, do you have a doula that takes you into birth? Or like, who's your midwife? Or like, do you have your meals prepped when you come home? And like, it is mind-boggling to me when I get like these looks and they're like, you're asking me where my meal is? Like, it'll be here when I come home. And I'm like, no, it won't. There's a baby in your hand. There's a box of diapers. There's probably other kids running around. Like let's talk. And like, I think that's where care needs to go when we talk about collaborative care, like really finding out what resources. It's not just about the mom, which, as a woman, like I'm saying that, like, I think it's like looking at the whole picture and like who's involved and who's not involved and like what do we need to really get them.
Yeah, I'll piggyback on that, Tulsi, because first let me start with the partners, because what typically happens is people want to come, they want to talk to me about fatherhood, and they want me to lay out some like really sage advice about the partner, and it's usually through the lens of it's hard for dads too, and actually I don't really care about that party line. It's about the family. It's about this person is going to go back into a home isolated from all of her neighbors, maybe doesn't even know their neighbors. And then they're going to figure out how to take care of this newborn without any real instruction. They got a shaken baby video in the hospital. That was they're solid, right? They got maybe some lactation support, and maybe they got some time off from work. And that's really the best we can do in society. So, for us to, I'm going to push back a little bit on what Tyler said, for us to push back on I'd like to push back on this notion that like, hey, this is how it is and we just need to make it better. It kind of feels like rearranging the chairs on the Titanic as it's sinking. It also kind of feels like trying to polish a turd and give it to somebody as a gemstone. Like it's not polishable. It is profoundly, it's not broken actually. It's actually a profoundly well-oiled machine. And to not sound too doom and gloom, when we talk about what collaboration can look like, I made a pretty easy decision. I got booted out of the hospital system during COVID. So it wasn't even my decision, I suppose. And I'm not sure if I could have made the decision because, gosh, the golden handcuffs are so nice when you're a doctor. And what I realized is people are going to midwives more and more. Still, a very, very small percentage of the population. So I started talking to midwife friends and started getting licensed in other states and realized, man, I can put my credentials, um, I can put those towards whatever I actually believe to be, true about this work in my heart. And I started working with midwives. I have no longer any renewed hospital privileges. I was not denied them, but it also wouldn't be responsible for me to do C-sections and all of that. And the reason I'm saying all of this is that as an individual, I see, hey, there's a profound need here. I'm not going to make as much money. Maybe I won't have the 401k. I won't have paid paternity leave or whatever the hell, those little Easter eggs were that they were placing in those contracts that made it seem good. And now I actually have more time with my family. I actually get to spend as much time with clients as I want. I charge $100 for a consult. $100. Like anybody can afford $100. And if they can't, I just give it away for free. And so the point here is that I don't think it's sufficient enough for us to just say, hey, this is just how it is. Let's just make it better within that, within the constructs of what has been built. Krishnamurti, he had said it's no measure of health to be well adjusted to a profoundly sick society. Like, do we really care about this? If we really care about this, we have to actually be willing to look in the mirror and realize just how dysfunctional this very, very well-functioning system is. It's functional for a specific purpose. It is dysfunctional if you're the patient, if you're the father, if you're the baby, if you're a midwife, if you're a doctor, if you're a pelvic floor physical therapist. This system doesn't work for you. And heaven forbid you went to medicine through a channel like Chinese medicine or Ayurvedic medicine, which predates Western medicine by several thousands of years, if not 10,000 in the case of Ayurveda. But who's to say that works? That's junk. That's not science. Of course it is. It just hasn't been built into the business model. And we won't get into the Rockefellers and all that. That's really inappropriate right now. But yeah, I'll leave my piece there.
No, and like I said, I encourage and celebrate everything that you're saying, and I think it needs to be heard. And it's unfortunate that I think, and not to, I almost feel like I victim blame a little bit here, but like the patients and like families, they don't know what they don't know, right? So they can't up in arms scream from the top of their lungs that this doesn't work for us anymore. And most of us, me and my co-founder, we were actually talking about it yesterday because we're coming out with, a program to help, with the cohesion and stuff. And it's like, if you're not in this space, if you're not part of the perinatal ecosystem, you don't realize how important these topics are. You don't realize, you don't know the maternal mortality rates. You don't know all of the stuff that can really happen when you walk into that hospital, and you just think the 39-week induction is normal, and you just think that if you have one C-section, you have to have a scheduled one for your second. Like, there is no one, I mean, the education piece, right, goes back to fifth grade elementary school when you're separated boys and girls and you watch one freaking video on how your body works, and then that's the end of it for a very long time, right? Like, that's and we can get into the school system and how messed up that is too in this country, but to your point, not to doom and gloom, but I think, again, these conversations are really important. And I kind of love the contrast here. I didn't actually even plan on this, but like between Tyler, you really have a front seat to see in these hospital systems. And, I would love to actually, and again, we might go off on tangents, which is totally fine here, but from your perspective, Tyler, like, the boots on the ground people that are working in the team birth program, like, do they feel optimistic about it, or are they burnt out, or like, are they seeking change in some way, or are they just totally happy with how things are? Yeah, Rose, I would love to hear your perspective too, because I know you've been in the grind as a nurse in the hospitals and stuff. So I'd love to hear your perspective on all of this as well.
Yeah, and I love the fact that we're super aligned here, right? Um, and I do agree that systems work as they're designed. We have to hold space for that. The focus this year, Nicole, I think you know, but no one else, the focus this year of our conference in the fall is innovation and reimagining healthcare, because I've been saying since I was at Emory 2023, I started saying it that no one's coming to save us. I could see in 2023 that we were kind of spiraling out of control. Healthcare nationally was spiraling out of control for many, many reasons. And my goal in saying that to the team was to tell them and remind them that we're the ones we've been waiting for, that we have the answers, right? And it's incumbent on us to be bold and to be innovative and to be creative, so that we can provide solutions within a healthcare system that's imploding. What we're doing now is not sustainable. I have deep fear of the future for healthcare, for many reasons that we probably don't even have time to touch on. But as a nurse, as an executive leader, I'll focus on nursing. And I'll say that when we are functioning so much as a business and we're measuring productivity in a way that really doesn't reflect the actual work of the nurses, and that and as a result of that, our staffing matrix looks a certain way, which interpreted as that we don't have enough nurses, right? And nurses are overburdened, they're overworked, there's safety concerns. All of that is really leading to the state of chaos that, I see in many healthcare organizations. And quite honestly, it doesn't have to be that way. It doesn't have to be that way at all. And I'm at the point now in my career that I want to be part of the solution, which is why we chose this theme. How can we be innovative? How can we reimagine healthcare? Because there were so many things that we did beautifully and brilliantly at Emory Educator Hospital. I'm super proud of our accomplishments. However, there was a point that, the rubber met the road, and regardless of any conversations around the need for resources, there was just a hard stop because there were limitations that was placed on everyone, right? Financial limitations. So I do believe that we're the ones to fix healthcare, especially the group around here. I believe that we're all innovative and creative to do that. And I think the time is now to do it, and I'm holding space for it, um, out of necessity, that we have to do that. Um, because at the level of turnover and burnout that I am seeing, it's urgent. It's a crisis that has to be addressed. Um, yeah, that's how I would respond to that part of it.
Yeah, go ahead, Nathan. You can unmute and just follow up.
Yeah, I have a question for Rose because I love what you said. It's really fresh for me for some reason, like something was stirred. My thought has always been, and maybe you have an answer for this, what metric could we use? You're a former nurse. What metric could be used by an administrator that would be helpful for determining how well administration is caring for nurses?
So there are some
I mean, I want to know
metrics
from
out
your
there.
heart, like
Yeah.
what as a nurse, what would actually have felt like, man, this hospital really cares about me.
So I would take it back to the patient's experience. I feel like that should drive everything. We have a metric around the patient experience. So for me, the patient experience, the nurse's experience, retention, and turnover. I think those are meaningful metrics. I think if you're doing a good job, your patients can feel it. Your nurses feel a sense of belonging. They feel like their voice is being heard. So I think that's all tied into each other, and it can happen. It can happen. Um, and I don't think there's enough. I think we lean too much to, again, it is a business, and there's certain, not even outside of the profit margin, there's, we have to be able to pay our bills. And I know the cost of healthcare continues to rise. I mean, we went live with Epic, and that was several $1 million, so I know that there's costs associated with things like that. But however, if we remember that the only reason why a hospital exists is for people, to take care of people, if we prioritize taking care of people, then we need to reframe how we measure, are we adequately, lovingly, supportively taking care of people? And I don't think that's the kind of conversation that most healthcare organizations are ready to have right now, because it's foreign, right? Even though that's why we exist. I remember many executive meetings having to say, sorry, because you have IT and you have pharmacy and you have all of these other departments. I'm like, I think we're forgetting that we're here for people. I don't want to hear about any of that. If we have to find a way to save a couple of $1 million, don't look at patient care services, because that's why we exist. But that's not always a conversation, right? The conversation is seldom around, oh, let's cut some money from IT. Let's cut some money from, I don't know, other ancillary departments. But we somehow believe that we can have a few less nurses, we can have a few less techs, we can have a few less other resources. And that's the wrong focus. That's always the wrong focus. If we exist to take care of people, people have to be our priority. And the money follows our priority, is what I believe. I don't know if I answered your question, Nathan, but hopefully I did. He's like, kind of, sort of.
I don't know if I froze or okay, just making sure. I think I see you guys. All right. Well, I love this dialogue. But I would love to I think we've talked about a lot of these questions already in some sort of indirect way. But I think a common thread that we're talking about is the patient, right? So from a perspective of, and I don't think this is even really on your list, so I'm going to throw this out there. But from the patient perspective, right? Like, how would you, how do I put this? Like, make them understand the importance of a cohesive team and hiring a cohesive team and investing in that, right? And trusting you in whatever facet you are in to give them that guidance, right? Because we know society doesn't, we know our healthcare system doesn't, but in my experience personally, my doula was that golden thread through all of my births. She was there for my hospital births. She was there for both my home births. She was there for my birth center birth. She was my trusted, guide through everything. And she introduced me to lactation support and pelvic floor therapy and mental health therapy and, all of these things that were in that ecosystem. And so I guess my question is, from your perspective, is that conversation even happening at any level, or is it something that is so low on the totem pole because of all the other priorities and initiatives or time constraints that are on? And how can we incorporate it into future conversations?
So, Nicole, I can answer that. Something that I have on my side is time, right? Like, as a provider and someone that I will say I'm in like the cash-based model for the perinatal space, I have time. So I actually will speak on like some of these things that I like kind of noted before, like who's there to help you, who's coming to your birth. Let's talk about your birth prep, right? Like I will do labor prep, but it's not just getting the woman ready. It's like, are your bags ready? Do you know what you need? Do you know like what you may not have? Like having these little questions kind of gets their wheels turning. And like a lot of times I'll even like say, let's bring your partner into this and like let's discuss this. And like I feel like there's so many bombshells like that are dropped that they're like, but where do I go to find the answers? Is it Google? And I'm like, no. And I will actually like keep a handout ready of like, here's lactation, here's like maybe stuff to ask your OB at your visits. Like here is this, here, like just to like kind of get them ready, because sometimes when you don't know, it's kind of like what you said, what you don't know is what you don't know, and what you know is what you know. But if someone's like throwing these things into the mix, then you also have to be ready to give them like opportunities of where to look it up. And I think simple questions like of like, do you know, how are you going to do this, can make a world of a difference. And I think that can only happen when you have time, which I'm lucky to have. But yeah.
I think Tulsi, I don't want to say challenge you too, but I think also the clients that you interact with are, I hate the word privileged, but like privileged in a sense that like most families don't even know what pelvic floor physical therapy is, let alone have one and actually go to it to be like useful, right? Prenatally versus postpartum when something doesn't feel right. So
Yeah.
I love that perspective, but it just, I want more people referring to people like you and you not having to be the one to be like, wait, you have me, get everyone else in there. Because, uh, my whole first pregnancy, I had no idea I've never even heard that word, right? I wound up at 15 weeks with my second pregnancy not being able to lift my legs because of some pelvic floor issues. And then, you know, found someone and luckily, connected with her and she was at my two home births. But, um, like I said, not everyone has that opportunity. So I love that you're having that, but how do we get that more integrated into everyone's experience?
I think there's an opportunity for navigation. I have a big, hairy, audacious dream of um, having a company that provides navigation. And I think there's a couple, as I think about Maven Clinic and I think about Pomelo Care, I think they have a program similar in place that engages early with the patient, right? Because we have to create that ecosystem for the patient that the patient's not aware of. So having somebody who is totally in charge of navigating the patient's experience, we have really great research about navigation from, I don't know, like 30, 40 years ago in the state of New York. But having that person, and it was around cancer, but having that person that can navigate, here's my vision. You engage, you find out you're pregnant, and we're not talking preconception. You find out you're pregnant, you engage with my beautiful company that offers navigation, and you're assigned a navigator. Whether it's a nurse or a peer, you're assigned a navigator. And the navigator does a warm handoff for you to your doula. Your navigator does a warm handoff for you to your lactation consultant. Your navigator does the warm handoff to maternal mental health. Every time you meet with a navigator at every trimester, you'll do the PQH-9 just to see where you are mentally, right? Your navigator connects you with your pelvic floor therapist. Your navigator connects you with acupuncture, acupressure. Your navigator connects you with cardiology, because we know cardiology needs to be in the ecosystem as you look at the rising rates of preeclampsia, right? But that one person, and you have that entire ecosystem as uh, referrals, and you have them as your vetted referrals so that you can do that. It's not like, oh, you need a pelvic floor therapist, good luck. It's like, no. I reach out to Tulsi and I tell her about it and I say, hey, I want to schedule an appointment. And the navigator does all of that. I think that is beautiful best practice. It's been something in my head that I dream of all the time, but I think I feel like that's ideal. Education is really great, it's powerful, but there's so many gaps when we just say, oh, we'll just provide education. Also, in my dream, the navigator also schedules the education based on your trimester, right? And then when you're at your third trimester, we'll start talking more about what birth is going to look like and all of the things that you need. So for me, that's what is needed. And again, I love that Maven Clinic is doing some things like that, and Pomelo Care is doing some things like that. And I'm sure there's um, other organizations that's doing that. And globally, that's what I would love. Well, forget globally, name it. Our, our morbidity and mortality rates continue to rise. Here in the United States, we could definitely benefit from making pregnancy, labor, and birth a priority because we know our future depends on that, right? We can begin to say women matter, women's voices matter, and again, put our resources where our mouth is and create something like that. I would love to be a part of that. Maybe there's a great investor out there listening and they're like, oh my God, Rose, that is transformational. I'm going to give you $5 million. Let's do it, girl. Yeah, I'd love to see that happen.
Tyler, go ahead. Yeah, Nathan, you can definitely follow up. I just want to also plug that the PRC is coming out with something called the Perinatal Resource Package, and it is a gift for all of our members to essentially gift all of their clients. So we're not marketing it directly to any families, but it's a way through our professionals so that the Google rabbit holes at 2 a.m. don't happen. And it's at least vetted resources, and it's not a provider directory because that gets overwhelming as well, but just, oh, where's your state? Here's the breastfeeding coalition. Here's the PSI chapter. Here's, these bigger organization navigation to your point, Rose, where at least it's a starting point that they can go to rather than Google and then the sponsored ads and having to figure out if they're being scammed or not, or like going into provider directories where there's 100 listings and trying to navigate themselves. So it's one of our biggest missions to obviously, we are through the professionals, but we want to impact the families. Oh, yeah, here we go. Say hi. She's got her first day of school outfit on. That school doesn't start for like a week and a half, but she has to wear it today. So, okay, relax. So yeah, Nathan, I'll let you go, but I just want to let you know that that's coming in September, so we're really excited about that.
Yeah, I was listening to Tyler, and I just wanted to name something, Tyler, that you did so beautifully, which is really, really important for this work. I also happen to be board certified in hospice and palliative medicine, and I know that Team Birth is part of Ariadne Labs, which has done some extraordinary work in that space. So I just want to name that. But the thing I want to name that Tyler did that was so lovely is that I could actually understand Tyler's point of view in helping support his brother without knowing anything about him. There was a feeling, there was something that he was moved by the experience with his brother that made him think about how we provide the provision of healthcare at the end of life or through oncology or whatever. And very few people were really doing that in the birth space. And Rose, I don't want to knock you here, but when I asked you about what was important to you as a nurse, you went through all the metrics that the CEO, the C-suite would have told me. I wanted to know what was important to Rose. You're at that moment where you're at the breaking point. What would have made a difference for Rose? And I don't want you to answer that now, but this is the way that we need to approach this issue. Women have babies not by thinking through birth. They don't say, I need to do it this way, and then I need to make sure my cervix dilates, and then this, and this, and this, and this, and this. They're actually very embodied in the process of having a baby. And we, as healthcare professionals, we go in, and I promise you, Tulsi, when she's doing, I maybe I'm presuming too much, Tulsi, but I think I've felt enough from you that, and in working with other physical therapists, that there's as much that your practice of helping to alleviate some pelvic floor dysfunction is requiring you to be fully embodied with that person. You're not really thinking your way through, you're feeling your way through. In the same way that I make love to my wife, I'm not thinking about how I'm going to have sex with her. We are flowing. The divine masculine and divine feminine are flowing together. And that same, the byproduct of that flow, that lovemaking, that embodied presence with one another results in a baby being born. And yet I'm going to come in with my big old sexy brain and I'm going to try to now reverse engineer this thing to make sure that the parts all fit together so that we have a baby on the end. And much of what I think many people were talking about as innovation in the space is really just doubling down on our tendency to think our way through problems without actually becoming embodied within the within the essence of the question itself. We use the word the system. Well, the system is a whole bunch of human beings that have this incredibly vast intelligence about themselves and about this experience of making love, having babies. All the people that are doing the things on behalf of the system have also had kids. And yet we're still like trying to come up with some artificial delusional way of looking at this as if it's just a matter of getting the system right. Whereas if each of us in our own families, in our own bedrooms, were to go in with that, we would end up falling flat on our face. So why are we falling flat on our face in healthcare? We're not embodied. We are still so stuck up here because education has schooled us into believing this is the most valuable thing we have. And yet the most important things we do come from here. They come from in our body. So I just want to like plug that. Nicole, let's put some resources in your packet to give out to people. Like this needs to be embodiment work. This needs to be dropping into your heart and really doing what's right for Tyler's brother. If Tyler came to me and said, can you help me with my brother? He's got Ewing sarcoma. I wouldn't be asking the oncologist for all the lab reports. I would want to know who Tyler's brother is. I would want to know who Tyler is. How is this affecting you? Tyler, what can I do right now to make your life better? I could use a beer. Let's go get a beer. It has nothing to do with healthcare. It's human to human shit. And we don't do human to human shit anymore in the age of AI, in the age of social media, in the age of rampant commenting from God knows what place it's coming from. But it's just self-criticism that's being projected onto other people. And then we go into the hospital system. We expect that the people up at the top are acting out of hearts and that's going to trickle down to us as nurse and other staff. It's not. It doesn't work like that. You don't think your way through having a baby. So what are we birthing together? Are we going to think our way into what we're birthing, or are we going to actually feel our way into what we're birthing? And how do we tender that baby once it's born? You don't love your child by thinking about what they want. Everybody knows that who has kids. You don't think about what they want. You get the diaper change, you get the burps, you get them fed, and they're still crying. That's time to be present with them, to co-regulate with them, to let them lay on your chest and breathe with them and really let them melt into you until they feel safe again. Nobody's feeling safe right now. We're all just trying to rearrange the chairs on the Titanic.
That was super powerful. Thank you, Nathan. I don't know if you guys have heard this, whether you're here, you're watching this on the replay, but there's a reel going around about if humans or babies come from a portal, right? Like a mythical portal, and how we would treat that portal space, right? If it was a location, how people would flock to it and people would pray at it and people would bring gifts to it. And, this theory of, well, women are that portal, but we treat them how we treat them. And, we expect them to, like you said, and I always joke around when I say this on Zoom or on Riverside or whatever, but we are floating heads. Specifically women, we are conditioned from so little, my daughter, 4 years old, you saw her, we're conditioning them, billions of dollars being spent in everything to just be floating heads, as you were saying, Nathan, everything up here and not connected to your body. And for those of you who know my background, before the PRC, it was womb work and energy work and somatic work and subconscious reprogramming and things like that. So it is so powerful. And learning all of that as I was also becoming a mom over and over again in the last decade taught me so much about, just myself and just how I interact with other adults and other children, and how um the parallels, right, to like your own feelings and emotions, and then like you said, like regulating with your children. And um it's powerful work. But even my father, or people in my family who don't understand that aspect of it and who won't subscribe to it, they're like, oh, you're woo woo shit. And, oh, everything I did about birth, with my last two was, why would you do that? Oh, you're not going to cut the cord? Why would you do that? Why would you want to hold a placenta for a few days? Like, oh, you're going to have birth in your bedroom? Like, why? My last son, I wouldn't let anyone hold him for 2 weeks because I really wanted a successful breastfeeding relationship. And I was like, no other microbiomes coming on here, just me and him. We were basically like naked in bed for, the first week. And I won't knock my father too much, but he's just a very old Italian man. So he's in that generation. And he's like, can you just put damn clothes on that kid and send me a picture so I could post it to my friends? And I was like, yeah, Dad, that's the priority, right? That's the important thing right now. Like, no, you could wait. But I've always been a black sheep, right? Like, I'm comfortable being that black sheep and doing things that might not get approval from family. But I think so many of us, like, again, we're conditioned as children to like just seek validation, seek approval. And that goes for your doctor, that goes for, again, your partner who doesn't know any better to say, oh no, you need to do it this way. Your parents who are like, no, we went through the system, you have to go through the system. So I think, to everyone's point, like, we are just so disconnected in society because of all of these things. And I think it's shifting. I like, in my heart, I feel like we can't go too much longer in this direction without a pivot. And I think these conversations are happening more often than they ever have before because of it. And I know that that still doesn't, mean that everything's going to be butterflies and rainbows, but I think at least we're, I'm someone, again, if you've talked to me for more than 20 minutes, I hate meta and I hate the algorithms and I hate being like censored or told, when I'm going to be seen or not. And, but social media does have a positive, right? I think I'm pretty sure I've connected with every single one of you because of social media, right? Like, so that there is positives to it. But I think it just needs to be used in a more appropriate way rather than how it's being used right now. But that's a whole other tangent. Tyler, do you want to add something? Yeah, there's no rules here.
I think that's a great question. And that's definitely, that was my reality the last 3 years that I worked at the hospital. Um, at the end of the day, I loved the work. Um, I love the birthing community. That's why I chose OB. I chose it right during my clinical rotation because I fell in love with it. Um, so I understood that what we were doing was sacred work, while understanding that the system that we're working within does not understand the sacredness of the work, nor necessarily values it the way we do. Having said that, we were able to create our own bubble to protect us, right? I saw that as my job. As the executive leader, my job is to protect the team. So, what did that look like? I was committed to creating a culture of accountability, a culture of belonging, a culture of evidence based care. There were several tenets that I really believed in, that our leadership team really believed in, and that we felt that if we operated within these tenets, that we can create a really loving, supportive, nurturing culture. And we did that. We did that, as was evidenced by, you know, during a global pandemic that really was nothing that we've ever seen in our lifetime, right? That I was able to have retention of my entire leadership team. That during a global pandemic, that we had one of our highest patient satisfaction scores because of what we put in place, because of these tenets, right? The education that we put in place, the accountability, the support, the nurturing that we put in place. So, you know, many things can be true at the same time. Um, we know as professionals that as much as we'd love to, you know, burn up, as I'll just use me, as much as I would love to burn up our current healthcare system, you know, let it explode, I know that we have to work within it because it's what we have. But just because we have a healthcare system that's dysfunctional and doesn't suit all of our needs, doesn't mean that the units where we work has to reflect that. So many things can be true at the same time, and that's what we did. So I'm not saying that it's hopeless because it's not hopeless, right? We can find our joy. We can find our joy in the midst of the chaos. It's not mutually exclusive, and because of the results that we had, I mean, we brought on team birth shortly after the pandemic, right? Because it lined up with our initiatives. And our initiatives had always been around centering the patient. And I remember telling nurses, I said, what if centering the patient, doing all you can for them, was the way that we as clinicians could find our joy? What if that was like the missing ingredient all of the time, right? So again, you know, we put that in place because we wanted our patients to be empowered. We wanted to leverage shared decision making. We wanted to improve communication and make sure that our physicians, our midwives, and everyone felt a sense of belonging, that they knew what was going on. We wanted to put everything in place that made our operation as smooth, as efficient, as loving, as nurturing, as evidence based as possible. So that's how I would answer that. It's possible.
Anyone else want to answer Tyler's question?
I do, but I'm not sure what approach I want to take because it's a really good question, and I um I don't want to be too much of a sinker because you're right. And you know, if we were to take a 50,000 foot view of this medical system thing, there's no doubt that we are the best in acute care medicine in the world. The United States is. It works extremely well. if you end up having a true emergency, including in the maternity care system. 27 seconds or something was my fastest C-section, like getting the baby out. That's pretty awesome that we have all of the systems in place to be able to do that. Here's where I was kind of grappling with your question, Tyler, which is that if we presume that as soon as you're pregnant, you're now a patient, it presumes that there's some sort of disease process that is manifest as a consequence of your undying fertility. So now that you're sick, you belong in a hospital. That to me is already a poor presumption. And yes, that's where people were going, but that's because of what happened in the early 20th century. And that's because of a mischaracterization of midwives, which is a vastly different characterization in the United States compared to what it was just 100 years ago in many other countries. So if we presume that you're sick, we can now bill for medical services because if a sick person needs medicine. So I never even really told you what I did when I did my introduction, but I figured I don't need to be in the medical system. In fact, I was so butthurt about being fired for caring for a man in a very dignified way at the end of his life. I took my mask off and I trimmed his toenails, rubbed lotion on his skin, did all this stuff that my own grandfather, who died in August of 2020 at 100, and I didn't get to be with my grandfather. That's what I would have loved for my grandfather, but he didn't get that. And so in order to dignify this man who's 95 and dying of heart failure and whatnot, of course I took my mask off because he asked me to. And I was fired the next day. I don't really care to get into that. But the point here is that when I left, I had to really decide, is my heart really in this medical thing? And maybe it isn't because we've got a baby now and I'm going to be on call all the time. And do I need to be in a hospital to take care of a person who's pregnant? And the answer is no, because they're not sick. If they become sick, thank God we have the best acute care system in the world. Thank God that we have a blood transfusion, a pharmacist on site. We've got everything that we possibly could use in order to save a life compared to what we might have in East Africa, which is where I spent many summers in college. And so when we start to ask, like, what do we want the system to look like? We don't have to blow it up. I want to keep the system. I think we need the system, and we need education, and we need all this stuff. But where are the midwives? Like, where is the midwife in this panel, Nicole? Because they do this way better than I do. Unless the person becomes sick, and unless they need scalpel, they need surgical steel, unless they need a blood transfusion, unless they need some uterotonic in order to prevent hemorrhage after they've given birth, unless they need augmentation, unless it would be beneficial to the baby for me to artificially rupture the waters, unless there's some strange reason why they would benefit from continuous heart rate monitoring. Okay, so my point here is that we don't need to burn it down. In fact, we should be continuing to invest in improving those systems. But if we're asking the wrong question, which is what does a pregnant person need? They need love. They need to be with their partner. They need to be in their home. They need to find safety from start to finish. And if they don't feel safe in hospitals, it doesn't matter how many tapestries and artificial candles you light in the room. It doesn't make it any better. Because maybe somebody like me walked in and said, it's for the baby's benefit. I need to stick my hand inside of your vagina, which is actually reserved for your husband's penis. But right now I'm in charge and I'm going to have your husband hold you down while you say no and I put my hand in there. Like there's all that stuff happening as well. So we have to talk about workforce. We have to talk about efficiency. We have to talk about productivity. We have to talk about money. We have to talk about all those things in the hospital system. And we're maybe missing the question. We're missing the whole point, which is, what does this woman need? She actually needs my time. She needs me to be sitting there present with her. And if I need one of my colleagues to come into the room, then we call, Neil. We call whatever, any of the MDs that work in my town. And we say, listen, I think that this person actually needs help. And that conversation can be easily done by a midwife who is not a medical professional. They're a vocational student of life. And they embody with the biological elegance of like this whole experience of people caring for people, way more so than the C-suites and any number of nonprofits can do, especially if we're going to stay up in our heads and not in our bodies.
Yes. Thank you for that challenge, Nathan. I we did a whole midwifery panel in March, FYI, or no, in May, FYI. So, definitely a huge proponent of midwives. I think too, to get on that topic is we do midwifery care so badly in this country that one, there's no consistency through any states. Sometimes, some states, midwives are literally like illegal for certain things, and licensing is a mess. Uh, and I know midwives personally, home birth midwives here in New Jersey that one needs supervision from an OB to even practice, and then their credential isn't good enough to sign paid leave forms or to, comfortably transfer to a hospital when, a patient needs that care, or they can't go with them, or, it's another example of the lack of collaboration and the lack of understanding that this ecosystem does need to coexist for that patient or for that family. Because, and I say this all the time, one OB, one midwife, one doula, you could be the best at what you do. You still can't support every single need of a birthing family, from fertility through postpartum in all aspects, right? It needs to be a cohesive ecosystem supporting that family in all the ways. And it doesn't, like you said, doesn't need to be in a hospital setting. It doesn't need to be in a doctor's office. When I first hired my home birth midwife, the biggest things that I raved about to my friends and stuff to say, hey, you guys need to, look into this option, was I didn't have to go into an office. She came to my house and sat with me. And my children were able to like be involved and use the Doppler on me and really be part of that experience because they were at the birth. And it was such a different entire journey with midwifery care than it was going to an OB office, sitting in a waiting room for 20 minutes, talking to them for 5 minutes after they did an internal or, did whatever they had to do, and then drive back into my car and drive home and be done for the day. And that is so much more even than just the day of the birth, right? Like that is, maybe it's not one day, like a couple of days, right? All my boys kept me in early labor for days, but that's that one circumstance, that one, event. Whereas the whole pregnancy journey, the whole postpartum journey is so much more than that. And the midwifery care before and after, I think, is so much more profound, right? Like, I forget who said it, at 6 weeks, right? OBs can see at 6 weeks and sign off on your birth control and that you could have sex. But my midwife showed up 24 hours, 48 hours, 1 week, 2 weeks, 4 weeks, 6 weeks, right? And it was all encompassed in her fee that she was paid. And I think that's the missing piece of what we talk about in this country a lot, is like, oh, we talk about home birth, the actual baby being delivered outside of the hospital, but the care that you're provided both prenatally and postpartum by a midwife is at such a vast, it's so relational and not transactional, right? There's so much to it. And I love, again, sharing my experience, but there's so many people that are like, wow, I never even thought of it, right? Again, you think home birth, you think midwife, and you think of that one event that happens, right? Baby coming out, but it's so much more. So, Tyler, again, I love that you posed the question, and I think it's important, right? And again, I think unfortunately the constraints always come back to money. Because, my hospital birth, I had, my husband had good insurance at the time. He worked for a school system, and I paid $0 for that hospital birth. But if I looked at the bill, it was probably close to 19,000-20,000. But I didn't feel that. I didn't see that. And then my home births were, 6,500, 7,000 out of my pocket. And that's a scary number for a lot of people. It's an impossible number for other people. And again, you think, oh, it's just the birth, but that was all prenatal care, all postpartum care, everything that I just discussed. So when you ration it out, I mean, that's nothing. But the labor of having to, meddle with your insurance company to get reimbursed for even some of that, it's taxing, and it's another thing that like women don't want to do while they're pregnant and postpartum. So it's like, I think that's the solution, right? Like, how do we solve for that component of it to make it possible for more women and families to see, oh, look at when you compare them, right? Like, there's no comparison in the two experiences. People will always choose, the human person will always choose that route, right? And to Nathan's point, thank God we have the system if preeclampsia starts, if hemorrhage happens, if whatever, list of things comes to fruition. But villainizing midwives to go into hospital systems is not the way to fix that solution. So I'll get off my soapbox now. All right. Well, I always try to end these on a positive and like action-based question. So like, again, we know that burning down the entire system or reconfiguring the system or, just making society totally understand all of these things is a huge feat. But like, what is an action step or one pivot that we can make individually or within our current spheres to support that cohesive ecosystem and to support more education or more awareness of these solutions in your area? So whoever wants to start.
I'm happy to start. So, as a self-employed person who's doing consulting, I have total control of what Rose Wharton does. So that's why our theme for our conference, I wanted to hold space for innovation and reimagining healthcare. So along with the conference, I am having a hackathon that was bigger than I anticipated, let me tell you. I'm like, that sounds like a great idea. And the whole goal of the hackathon is to get creative minds from students and also from people like doulas and lactation consultants and pelvic floor physical therapists. What we know for sure is that people closest to the problem are closest to the solution. And that's the whole goal for my hackathon. This year, 2026, has been, for me, a year of solutions. We've brainstormed, we've researched, we have data ad nauseum, yet our outcomes are still not changing. So I said, what can I do within my locus of control? And those are the two things that I said I can do, have a theme and center speakers around that theme, because there are pockets of people who are doing amazing, wonderful, beautiful work. Team birth is definitely an example of that. So that's what I'm doing, holding space for that and having a hackathon and getting creative, brilliant minds and the hack that they're focusing on, hey, how do you mitigate maternal and infant morbidity and mortality? The shame of the United Healthcare system is the fact that 80%, 87% to be exact, of our mortality is preventable. I'm ashamed of that. I'm horrified. What can I do? So that's what I'm doing within my locus of control. I speak on it across the nation. I go to healthcare organizations. I keynote to talk about the power of nurses, because I'm a nurse and I know that we're the largest healthcare contingent, right? There's 4.5 million of us. We have 24-hour eyes on our patients that we care for within the hospital system, if that's where people are choosing for care. there are things that we can do, right, to mitigate morbidity and mortality. So I speak to that. It has become my life's work. And that's what I'm committed to continue to do, to be part of the solution, to have actionable work that I'm contributing to the work. And I think one thing, Nicole, the fact that you're holding this platform of panelists to talk about collaboration, you're definitely doing the work as well, right? Getting many voices to come around a solution. So I appreciate you from doing that, and everybody who listens to this discussion, the recording, whatever little snippets you pull out. I think everyone who loves the birthing community has a responsibility to say, what one thing can I do? What can I contribute that is solution oriented? Whether it's how I show up at work, do I show up with a spirit of humility, with curiosity, with love and joy? How do I show up? Because we can control that. So that's my call to action to everyone. What one thing can you do to be part of the solution?
Beautiful. Thank you so much, Rose. Anyone else?
Mine's easy. Call the midwife. That's it.
So for me, I think I challenged this a little bit from what I've kind of heard is, there's a system in place and we're not necessarily saying like, let's burn it down or, you know, let's take it away. I think we're trying to rebuild it and make it better. And I think a part of that question has to be like, just looking at this panel, right? Like so many of us have in a way left that system. And like, I think we have to look at it and see like, why? Like, yeah, we didn't like the system, but like, why? Like, is it because we were burnt out? Is it because, we were nicely asked to leave because we didn't wear our mask or like we had too many patients? Like, what is the actual why, right? And then for me, it's kind of like education is key, but like also to like what Nicole said, like accessibility, right? Like, I have the power to give this access and like to give people this like education, but 100% like only to the people that like I can touch and like, be in reach of. So like, how do we communicate what we have? And like, I say this from kind of like Tyler, like I have my public health degree as well. And like, I don't think it's just communication or access or education, but like in really to like build the system up. And I think we really have to find out what really truly works, and like that is, I think, so much of a bigger question. And the only way you can really answer that is like, why are so many of us leaving the system? To like, what is our goal? And the goal is to make it better. Like, what have we done individually to make it better? And I kind of agree, like finding that why is really going to be the one thing that I think really helps us not only connect to like everybody, but to make it such an incredible, powerful thing, because there's parts of the system that are working in other countries. And like, how do we bring that all together? Because like Nathan said, like we do have great acute care. We do have a lot of great things, but like, how can we make that to be like a powerhouse?
Yes, thank you so much, Tulsi. All right, Tyler, last but not least. Awesome. I have a question that just came to my mind because I think again you have a different view point than most of us, Tyler. How how many of the current hospital systems that you guys work with include like real important real importance on midwifery care versus hospitals that you see that don't have that integrated at all? Like, is it a profound difference or Yeah, I was just curious because I was like, oh, is it all, you know, the states and the hospitals that are like, oh, this makes sense because they already kind of believe in that? Or, and I know we've talked about this before, but like the southern states, right? You guys are really trying to get into those areas. And I know those are the states that have terrible midwifery laws and licensing and different things like that. So there's definitely a correlation, I think, too. Also, just to point out, I don't think there's any other country, and I haven't, been around the globe or anything, but I don't think there's any other country that operates 50 different ways for the same process, essentially, right? Again, depending on where you live really depends on what access to care you have, which is crazy if we're all under the same country. So I think that's definitely worth. Yeah. Yeah, for sure. All right. Well, I am so, so appreciative of each one of you taking the time today. I know it's, August, summer, back to school for some, depending on where you are. So I appreciate anyone who joined us, you guys on the panel. This is obviously going to be recorded for our members. So if you're watching this and you have any questions or you have any comments or, want to connect with anyone who's here, please reach out and I will connect you. And the listing will have all their information as well. Um, but yeah, like I said, thank you guys so much for being here. This is a great conversation. I think I only asked one actual question, so that was cool. I love when the conversations just organically flow so much more than here's my list of questions for you. But I have them just in case. But yeah, again, thank you guys so much and have a great rest of your summer. And for those watching, our next one will be September 17th, and we're actually going to focus on postpartum psychosis and maternal suicide awareness from multiple postpartum psychosis survivors. So that'll be a really interesting conversation. All right, thanks. Have a good day.